All right. Welcome, everyone, and thank you for joining today's webinar to learn about how to prevent Medicaid denials in community health centers and behavioral health. So, if you're late to the party and watching the recording in your car or on a walk, welcome to you as well. So, the baseline is this: our clients are our teachers. So, we will be telling you of the evolution of front end technology, really guided by some of the leading behavioral health organizations and community health centers. So we'll start with some intros. So today's panel includes our very own Zia Buddha. He is the CEO of Cordio Health. He is a serial entrepreneur and healthcare technology investor. So Zia, would you like to share any words about your background?
Good afternoon, good morning for some of you. Thanks, Gabe. As you said, this is actually my fourth tech company, and healthcare is personal. I won't go into the details, but it's something that um, I think the way the U.S. healthcare system is what it is, but we have a strong belief that when a provider provides a service, whether it's nonprofit or not, they ought to get paid so that they can continue to provide a level of service that the patients expect from them. So that is the that is our philosophy to help the providers uh, anticipate the denials and work through them before they even happen. So that is the core founding principle for Cordia. And it's I'm glad to be here, and thank you for having me.
Absolutely. And we're happy to have you, Zia. So, not to mention, one of the people most beloved by our clients, Rano. I mean, I think he's a healthcare rev cycle expert. I've heard some call him Mr. Denials, but I call him Rano. So, feel free to share some words, Rano, about your background here.
Yeah, absolutely. Once again, good morning and good afternoon, everyone. Thanks for joining us today. My name is Rano. I'm the Director of Healthcare Automation Solutions at OpenBots. And I'm very happy to be alongside Zia and you, Gabriel, today, just talking about certain things which means a lot to us. Just piggybacking on what Zia said, it's really important for us as an organization to help healthcare providers get paid for the services they're providing to their patients. And that's kind of like the core philosophy and foundation of Zia, which we are essentially following. And I think at the end of the day, we also feel grateful because of the fact that this is one such area which needs innovation, which needs technology. So I think we are at the right place at the right time.
Yeah, I think one thing I love about healthcare is that we really genuinely are all focused on the patient along with the bottom line, but both go hand in hand. So, my name is Gabriel Skelton. I am the head of sales here at Cordio Health, and we're all about preventing denials and eliminating denial rework at the front end. And specifically, we do it a lot for behavioral health, for FQHCs, for CCHBCs. So we're going to focus today specifically on that. So whether you're a certified community behavioral health clinic, whether you're a federally qualified health center, whether you're a treatment center, substance abuse, this is the space that we're focusing on. And one of the reasons why is because your patient populations are often heavily on Medicaid or ACA marketplace plans. And that matters because this group tends to experience pretty heavy denials for a lot of reasons, which impacts, again, the care they receive and the bottom line of the healthcare orgs providing that service. So in our world, what we see is when you're dealing with something like Medicaid plans frequently change. They can cycle on and off every month, which can cause denials. Number two, Medicaid is income driven. So a patient's job change, if they have an increase in their income, can make them no longer qualify for Medicaid, denial. Or number three, and the most important one, is that Medicaid is always the payer of last resort in terms of coordination of benefit rules. So that's an immediate denial if you bill Medicaid first and you don't realize they had a commercial payer or you didn't bill commercial payer first. So those are the top three reasons, but let's dive deeper into it. So Zia, let's start with you. You've talked about how Cordio is basically the iPhone moment for healthcare RCM. What do you mean by that?
Thanks, Gabe. So, I mean, if you look at most of the RCM tools and most of the RCM AI companies around you, many of them just focus on individual tasks. So, at Cordio, we looked at the entire revenue cycle journey. We identified where revenue is at risk. And that's a moving target. And that's also the innovation that we continue to do within our product. Um, just like, an iPhone, if you look at iPhone, if you look at the capabilities of an iPhone, it's an operating system, it's got applications, and there are things that you can continue to build on it. And Cordio has a similar philosophy. So Cordio not only has some of the built-in solutions for eligibility and verification of benefits and prior authorization and some of the mid-cycle and back office functionality, but we're also a full AI and automation platform with an operational intelligence built into it. So it's not just another point solution. From automating to front, mid, back cycle processes to patient communications and the ability to integrate with EHRs through the Cordio Health Bridge, a product. Cordio is a comprehensive platform for revenue cycle management with pretty much AI at its core. And you see, something that I've just mentioned earlier. I mean, you see a lot of AI companies being created and funded with crazy VC money. Some of them have already folded. We have seen that, Olive AI and Thoughtful and some of the others. The issue that I see for many of these is they're focused on gaining fast revenue momentum, which is understandable. VCs and private equity have revenue objectives, but at Cordio, our philosophy is to continuously nibble, at the denial, anticipation, and prevention, so we can stop the denials before they happen. And that's why we stay self-funded and organic and take the long road.
Very well said. And to your point, it's front, middle, and back matters, and the front is one of the biggest areas we focus on. And one of the reasons why is that eligibility is the most voluminous and expensive transaction in healthcare. Just coordinating benefits, eligibility, making sure that patient is fully verified, and it's often overlooked because there's so much integration that exists. Every tool has some kind of eligibility module that makes it feel like it's a solved problem. However, if you look at it, denial rates have gone up, have been increasing, even with the advancement of EHRs being connected to clearinghouses. So it's a deeper problem than just getting connections. Let's get deeper into that. So Rano, walk us through what actually happens today when a health center or behavioral health org checks eligibility with a standard clearinghouse. Where does that process break down?
Yeah, absolutely. Well, mechanically, if you think about the insurance verification process for a community health center or a FQHC, what you're essentially looking at is the front end team is responsible for running the insurance verification of all patients. Now, one of the typical scenarios that we have observed is the reliance on the EMR's native eligibility feature to verify the insurances of all patients. So if you are an FQHC and you are using NextGen, or you are using eClinicalWorks or Epic, you are essentially relying on the RTS feature, which these tools are going to provide you with. And then you're going to run the insurance verification process for all of the patients who have an appointment in 48 hours or 72 hours. That's like the standard process. Now, this particular process has a lot of cons and some of the areas which we are trying to mitigate with our Cordio Clear, which is the insurance verification product. One of the first things that we see is the EMRs have a native insurance verification feature, but that particular feature is only going to support one specific clearinghouse. Now, if you're dealing with FQHCs and community health centers, you are already dealing with a significant Medicaid population. So the blind spots for the CHCs and the FQHCs are Medicaid MCOs and region-specific state plans, because most of their patients would be on Medicaid MCOs. What we do is our platform is going to come in, and it's not just going to give you an integration with Availity and Navinet and that's it. Cordio Clear is going to sit on top of multiple clearinghouses and direct payer portals. Now, based on what the inquiry is, meaning what the patient's health plan is, we have the capability to take this particular inquiry, understand which health plan the patient is on, and go to that specific health portal to fetch the information. In the absence of what we call as an aggregator of aggregators, meaning going into multiple sources to find the information, you need a front-end guy on the FQHC side who needs to now call the insurance company to find the insurance benefits of the patient or log into a portal to find the information of a Medicaid MCO. That's number one, I would say. Number two is essentially a big problem that we see with our clients who have a Medicaid heavy population. Many situations arise where the insurance verification detail provides you the fact that the patient has active insurance. But active insurance doesn't necessarily mean billable coverage. A patient can have a healthy active plan, but the service that the patient is getting the service on might be covered by a different entity. We sometimes call this as carve outs. Or the patient has an insurance which is enlisted on the EMR, but the FQHC does not know whether that insurance information is a primary or a secondary of the patient. The moment they are going to send the claim to the insurance company, they later on finds that the insurance they had is a secondary. And in reality, they are billing the wrong insurance company for the service that has been rendered. So I think that's the another area where we come in. It's the way we use AI to find whether the patient is having any more insurances beyond what you have in the EMR, and the insurances that we are finding, which one of them is primary versus secondary versus tertiary. The last thing I would say is a re-verification process, which is very important for particularly Medicaid heavy populations. You know, in many situations, Medicaid churns out a lot faster. We have all seen it. A patient who has a Medicaid MCO on 25th of the month might have a different Medicaid MCO on the 1st of the next month. Unless you're re-verifying the insurance of that patient one more time, you have an outdated information on your EMR. So there are multiple angles and areas in which we see there is a breakout that's happening. And Gabe, to your question, we come in these particular spots to fix those issues so that the insurance is kind of accurate, it's reflected in the right way in the EMR, and these healthcare providers are not billing the wrong insurance company in the first place.
Very well said. You mentioned a lot of things, and even to your point on the verification checks, making sure you can do it for every appointment and as close to the appointment as possible. Now, the point here is that one payer can be on multiple clearinghouses, right? And you can have correct responses from one clearinghouse for that payer, incorrect responses from another clearinghouse. So you can't always get the full benefit picture of each patient when you're relying solely on the clearinghouse that your EHR allows, right? Unless you're going and manually checking every single one and then manually interpreting every response, which takes a lot of manpower to do. So the point is that you can actually you can get accuracy that goes up much higher when checking multiple clearinghouses. So to your point, instead of using only an aggregator like Availity or a Navinet or an Evicor or a Steady or a Waystar, what if you can aggregate all the aggregators for each check? That's the future of it, right? Because today it's often decentralized in the way that most of these orgs run eligibility, right? It's usually a handful of folks at each location and no real owner. And if there is a centralized team, then that team is still doing so much work manually going to payer portals. Like in Missouri, it could be going to Seymour, or in Oklahoma, it can be going to OHCA, or in Tennessee, going to 10K, or in California, going to Medi-Cal. Like those are 4 different states with 4 different complete different programs. So a lot of these orgs operate in many different states. So think about how much work it is to go in each one. So let's actually jump to you, Zia, because we've talked about denial rates, how they're climbing so much. I mean, it's 12% nationally in all of healthcare. When it comes to ACA, even in-network ACA, today it's 20% denial rate for in-network ACA marketplace plans. But let's go back to Cordio. So Zia, you've built Cordio really around automating healthcare operations. Why specifically did Medicaid denials in community health centers and behavioral health become the problem worth solving today?
So I think most behavioral health and community health centers are working on very thin margins, right? And they face very complex eligibility and managed care rules. And it goes back to the our founding principles. We say that if the provider provides a service at good faith, and regardless of the fact that maybe nonprofit or they ought to get paid to continue to offer the services that they provide to the patient. So we see an opportunity to prevent the denials before happen and improve the cash flow while freeing the staff to focus on patients. And it's at the end of the day, it's going to be fast changing pay rules, staff turnover, training gaps. These are the things that create problems for many of these folks to get paid quickly. So it's I think it's we have to solve for those thin margin problems. Many of them are negative. So that's the other thing. And most of Cordio solutions are designed and priced where we get paid on outcomes and not just on service.
Very well said. And what's happening now is that, I mean, the big beautiful act is coming, right? In terms of the next change is that it's going to move towards redeterminations coming every 6 months instead of annual. So there's constant changes. I mean, back in 2023, there was a change where 25 million people lost Medicaid coverage. So all of these changes and trying to react with them manually can be difficult. We talked already about how Medicaid plans frequently change. We talked about how it can be income driven. So a Medicaid patient can automatically be, they can no longer qualify, which again causes denial, or just making sure that Medicaid can be billed as the payer of last resort, and not understanding how many payers are involved for that patient will make sure you're immediately denied, or not sequencing them correctly. So that's the point of this. So in ACA, a big piece is if that patient stops paying their premium, they actually have usually 90 days of a grace period, where if you go to the payer portals, it'll show up as green active. And therefore, you're actually accepting a patient who, but the point is that you want to make sure that every patient gets what they need and is paying you, and alerting that patient and saying, hey, that premium was not paid. Can you cover this? And that way your bottom line is covered and that patient's receiving what they need. So Ronald, let's get deeper in terms of what you were saying around COB issues and carve-outs. So tell me a little more about this. This is one of the areas where a lot of the eligibility tools kind of fail, of making sure you can understand the picture of the guarantors or the insurance companies or the payers for each patient. So how does the AI aggregation layer resolve some of these primacy and secondary gaps that exist and catch it basically in real time?
Yeah, absolutely. One thing that we have to realize is coordination of benefits is not an eligibility failure. Coordination of benefits is only going to arise at a certain situation where you do not even know what sort of rules you need to apply for patients who have multiple guarantors, multiple insurance companies, right? Um, it's a typical problem. Just piggybacking to what Zia said, it's a massive problem in community health centers. It's a problem for FQHCs. The first example that I think of is the work we are doing with this Tennessee-based FQHC, who have almost 70% of the population on TennCare, which is the Medicaid program for Tennessee. And if a patient has TennCare, then the patient can be eligible for three types of Medicaid MCOs. One of them is WellPoint, the other is Blue Cross Blue Shield of Tennessee, and finally there is United Healthcare Community Plan. Now the problem this FQHC from Tennessee was running into is that they know that I have a list of patients who are eligible for the TennCare program. What they didn't know is that which insurance or Medicaid MCO the patients are on. And their staff had to manually call the patient every single time and take that information from the patient as a source of truth for which MCO the patient is on. Now, we have always seen it, particularly in the rural side of things, the patients are not always updated about their own insurances. So if a patient comes in and informs this Tennessee-based FQHC that I have WellPoint as my MCO, then there's no other alternative for this FQHC than to blindly believing the patient and billing the claim out to WellPoint. But what they have found is that in many situations, WellPoint was not the Medicaid MCO for that patient. WellPoint did term out in the middle of the month, and right now the patient was on United Healthcare Community Plan, which is a retroactive denial, which we always talk about. Where do we come in? We come in exactly those places where we are able to gather what MCO the patient is on. We have clients which are FQHCs and community health centers across multiple states. Straight out of the bat, I can think of Oklahoma, Tennessee, Missouri, California, so on and so forth. So the fact that we are not just able to go into Availity, Navinet, United Healthcare for commercial plans, but more importantly, go into a Seymour for Missouri, go into a OHCA for Oklahoma, or go into 10 care programs for Tennessee-based groups and retrieve the information from those particular programs is giving us a huge lever to find out which patients are on what sort of health plans. That's kind of where we come in. Baked by that, you already have the so-called traditional coordination of benefit rules. If you think about the parents dependent rule, right? I mean, I'm a child, I do not have any active insurance of my own. My mom has one insurance, my dad has another insurance. What is going to be the insurance that I am going to be dependent on, which is the birthday rule that gets applied? In other situations, we know that Medicaid being the payer of last resort, which gets applied. So systematically a platform that is taking into account the rules that is available in specific states, regional plans, and at the same time also taking into account the traditional COB rules, which is published by CMS. If we are looking through these lens and trying to capture all of this information together and bake it into one product, that's where you can discover certain things which you do not get to see through one clearinghouse, I would say. That's where we come in, and that's how we try to tackle the coordination of benefit problems, Gabe.
I love that. And Zia keeps mentioning catching a denial before it happens, preventing it. How do you do that? And to your point, when you deal with, for example, CCBHCs, at times they're not just dealing with COB rules, but they have to apply COB rules and specific rules per service line. So it gets even more complex. And that's why they're dealing with sometimes not just one or two insurance companies, they're dealing at times with 3 to 5 to 7 payers or guarantors for each patient, which adds another layer of complexity, hence why behavioral health specifically can at times have higher denial rates on top of this Medicaid heavy population that could change a lot. And to your point, I mean, we have had so many situations where staff said, I have to call the patient, and they didn't recognize there was a way to not need to call the patient to grab their insurance, whether it was checking multiple portals, whether it was, hey, let's actually automate a few texts for your patients who have opted in to actually ask them for their insurance card. Things like that can actually help and move the needle. But the point is, all of these COB rules, Ronald, to have them just in your brain is very difficult to actually apply them. The one you mentioned was, okay, let's say I'm 26 years old and under, and both of my parents have commercial insurance. Who's the primary? Where it should be the parent that has the birthday earlier in the year. That's just a specific rule. Or hey, if Medicare Advantage exists, well, Medicare Advantage should take precedence, right? Or the Medicaid being the payer of last resort. So that's 3 of so many rules that exist that is simply better served for technology to handle and take over, rather than having people who are already burdened doing more manual work when they should be working on things that are specific to patients or specific to revenue or both. Now, Zia, let's move on to you. A very important question here. I mean, we've talked all day about how denial rates have climbed to nearly 12% nationally. It's even higher for ACA marketplace plans, even higher for Medicaid. Do you see this as a temporary spike? Is this a structural shift in how payers and eligibility systems work? Tell us a little more.
Yeah, I think it's a structural. I don't think it's temporary. I think the payer rules will continue to change. It's a game that is played every day. You have staff turnover within the providers. You have training gaps that exist, and all of that results in things that are missed. In things like, I mean, some of the things that you talked about, right? Verification of benefits and eligibility, and even when submitting prior authorizations and those type of things. So the whole point is that I think that reducing denials in general is an operational excellence imperative, right? And the operational excellence, if you look underneath that, it's again staff training gaps, processes and procedures. Maybe some of the bigger health systems are, might be more efficient. I don't know. I mean, again, if you walk into a Cleveland clinic here in Western Florida, where I go to, you can be, if you go for an annual, you can be in and out in like less than 30 minutes. So maybe they just have it, because of the resources that they have, the administration resources that they have. I mean, they've gotten it down to like a procedure that they can rinse and repeat. But most of the community health centers and the behavioral health organizations may not have those type of resources. And that is exactly where we think that AI can provide a consistent, intelligent layer that helps the providers keep up with the changes and prevent issues before they become denials. So that is what Cordio is all about.
No, absolutely. And we've seen the statistics around how, well, payers specifically actually have double the investment in healthcare technology that providers have, which makes a big difference. But there's a shift, and especially because of what's happened with language models, providers are a little more nimble. They can change things around a little more. I was telling Ronald a few weeks ago about the story, but I remember going to the ortho, and I didn't get denied, but I spent actually 62 minutes at the ortho just waiting because they felt they had to actually call to manually verify my insurance because they were adamant on calling when I even had my insurance card. So even it's not only about getting denied, it's about the inefficiency in the process today for each appointment that affects patients and maybe makes them think twice about coming or makes them leave, or it affects revenue and patients. So Ronald, let's go to actually the next piece, because I think is also super important. So success stories. I mean, we've talked about that one client that was a very large Missouri-based nonprofit mental health company, and they had a big COB denial problem, Medicaid denial problem. Tell us a little more of what happened to them. What were their challenges? How did they attack it and solve it with technology?
Yeah, absolutely. When we heard the problem for the first time, I mean, you and I, we were on the call. We remember very well, like they talked about coordination of benefits being such a big problem that they were getting almost 400 denials every single month, and that's just stemming from coordination of benefits. And obviously, we need to tackle coordination of benefits, but first and foremost, we had to understand what was the main problem. Now, what we did realize is beyond just insurance check and mapping the insurances in the right way, what this group had in unique element was, they had patients who were given multiple services across the whole year. So it's a mental health care group who is within the guardrails of CCBHC, and they have patients who are getting services like SUD, substance use disorder treatment, psychiatric counseling, detox program, and in fact, the same patient can get all these three kind of services. Now, their billing was a little bit unique, and that's where the challenges arise in the first place. So, if a patient walks into any of their clinics and the patient can have, let's say, 4 different insurances, the patient can have BCBS, the patient can have Medicaid MCO, the patient can have self pay, and the patient finally can have a grant program, 4 different guarantors. If the patient is getting substance use disorder treatment as the service, then the way this organization was going to build the insurance company was to figure out which among the 4 guarantors are going to be responsible for substance use treatment. Let's say that's Medicaid MCO. So, what they were essentially failing to do is that they wanted to make sure that for substance use disorder treatment program, let's make sure that out of the 4 guarantors the patient have, Medicaid MCO should always become the one which is primary. Now, let's say 3 months from now, the same patient walks into any of their clinic, and right now he is getting a different service. Right now he's getting a detox program. It could very well happen, and it has happened in multiple situations where for detox program, the patient's right guarantor should be BCBS of Missouri and not, in this case, Medicaid MCO. So in this case, if the service line is going to be different, the payer type also has to be different. So what we did is, for this particular group who was already getting a lot of denials, and they had a team of 8 who was just responsible for fixing the COB related denials every single month, We not only did the insurance verification step for all of their patients, but we built a ranking system for them, which was baked with service lines and payer type. Meaning, if this is the particular service the patient is on, what is going to be the insurance company which is going to take responsibility of that service? Let's make that as the primary guarantor within their EMR, which is NetSmart My Avatar. And I mean, it sounds easy, but it was a real difficult challenge that they were trying to almost scramble through every single month. With the use of our AI agent, right now, we are glad to see the results they're getting. The denials, like you mentioned, it has been reduced to 50 denials per month from 400 denials per month. And it's not just about the denials. Every denial that their team was working on through the appeal process was almost like a $50 rework that their team had to do. So there are multiple angles in which they were losing revenue. But once again, the technology is there, the operational process was fixed. And once again, as I said, we are glad that we have been able to give them results by which they are happy.
That's such a key point, Ronald. Like if they have a different service line for that patient, for that appointment, then the MCO actually changes, which has even more complexity. But I think the point here is technology designed by folks with deep revenue cycle experience is how you actually solve these problems, not just generic AI. And what we typically see is this. Here's the typical way we see the impact of automating eligibility properly. And I think it's really three main things, maybe kind of one hidden way to look at it. So number one is time savings, clearly, right? How much time total was being spent manually today by that decentralized team at each location, or by that centralized team, or the mix of both. Number two is denial rework. Well, how many denied claims do you have? And what we see basically validated by HFMA and MGMA is what you mentioned, is that there's a range of about $25 all the way up to $118 spent per denied claim to rework it. Now, one of our clients did a study that said it was actually $50 per denied claim for them. So if you think $50 per denied claim, that can add up very quickly in the hundreds of thousands of dollars being spent to rework every claim because you did not have the proper technology in the front end to fix it. And lastly, denials prevented. This is the piece that's most volatile and can be the largest. When you can prevent denials, the client you mentioned, Ron, I think it was like an 87% drop. Usually at a minimum, it should be around 20% to 50% of that denial prevention piece if you're putting the technology that handles the COB piece, which is usually half of all denials, and things like we discussed one client that said, hey, I have a big Hispanic population. I'm Hispanic, and there could be multiple last names. And just that in itself can cause more fat finger issues, which again causes more denials. So those are the three biggest pieces. And the last kind of secret one is AR. AR is harder to quantify because it's more of an indirect piece. But if you fix your front end problems, you typically see a big impact on lowering that AR as well. So Zia, let's move on to you. So for any community health center or behavioral health executive listening today who's almost like accustomed to accepting their denial rate as a cost of doing business, accustomed to accepting their bad debt today, what mindset shift do they need to make?
Yeah, this usually my answers are short, but this one is an interesting one. So I think the denials should not be accepted as a cost of doing business. Most denials are signals of an upstream operational problem, right? So the mindset shift is from managing denials after they happen to preventing them before the care is delivered or the claim is submitted. And this is exactly what you can use AI to make the prevention consistent and scalable. I mean, you can't change your course, ahead until you anticipate what's going to happen next. Just to give you an example, I'll go off the point here, but I'm a recreational pilot, and as you guys know, in aviation, the safety margins are very thin. We are always trained to anticipate, and what's going to happen next and stay ahead of the plane. You cannot, taking off in a plane or landing a plane is not like getting in a car and getting off of a car. You need to anticipate all the variables, the wind, the weather and all that kind of stuff before you take off or land, right? So I think it's the same philosophy here, which is what drives us, that stay ahead of the denials before they happen, and use the technology, and AI is the technology to give you that edge, and have that operational excellence, using AI and some of the technologies that are available today that were not available even a year ago. So that's really my philosophy, is to I think is just stay ahead of the denials before they happen.
Absolutely. I mean, good example with the recreational pilot piece. And I mean, payers are denying based on rules. And if they're denying based on rules, that does mean you can get ahead of it before it happens, not just react to it, but actually be proactive. I think some of the questions to ask yourself too is, I mean, if you think it's a solved problem with eligibility, I mean, is your staff still going to payer portals? Are you satisfied with your denial rate? What about your bad debt? Like, think through where you're at with that, and then think again, hey, is it a solved problem? Because more times than not, it's not, because the number one reason for denial is eligibility, registration, and COB. Now let's go to the last question, Rano, if you don't mind. So, I mean, I think we shared a lot of information around the problem today of Medicaid-heavy patient populations, ACA marketplace heavy patient populations, the ones that serve those folks, which are more times than not health centers, behavioral health, mental health. Tell us a little more. If someone is saying, hey, I have this problem, I do want to act on this, but where do I even start? Where do I go? I already have all this technology that does something for eligibility. What do I do? So Ronald, give us a little bit of advice there.
Yeah, absolutely. I think if you look at insurance eligibility verification as a process, then all the healthcare providers are doing it today. It's not that they're not doing it. They're doing it at the front end. They're doing it at scheduling process. They're doing it at the intake process. But I think what's the missing piece here is the re-verification process. Now, we are dealing with, like you said, FQHCs and community health centers. They have a heavy Medicaid population, and the Medicaid MCOs would churn at any point during the month. We have all seen that Medicaid MCOs churns thick and fast. So the re-verification process is very critical. So if someone needs to use AI, as they're already relying on some kind of a clearinghouse to run the eligibility check for all of their patients who have a date of appointment in 3 days time or 4 days time, what they're missing on is the re-verification step. So I think that's one area where we should instantaneously focus on, to make sure that you do not have the outdated insurance coverage of the patients on your EMR. So that's going to be advice, Gabe.
I love it. Well, all in all, I mean, I'll say one more quick story. Ron and I were talking to an incoming client, and then we asked them at the end. We said, "Hey, so hold on, what is your ultimate denial rate?" And then before they answered, "Hey, give me 1 second." They pulled out a very large binder and started going through it. And then we stopped there. We said, "Don't worry about it. We'll help you with it, because the point is this should be done with technology." Now, most orgs aren't that bad, but even if you have a lower denial rate than average, you probably have a lot of time spent on reworking denials, or just getting those denials to not go into bad debt. So that's the point of it. And I think Zia mentioned outcome-based approach. That's the future. When you're dealing with healthcare technology companies, push on an outcome-based approach, that you can reduce some of the risk, yet dip your toe into the technology, see the results, and then scale from there, and really make it a really big impact internally, as a lot of our clients have in this space. So thank you all for joining today. If you're interested, you can go to Cordio.com. And thank you very much, Zia, as well, and Rano, for the time spent today on today's call. See you.
Thank you.
Thank you so much.